Discussing today will be the indications of laser angioplasty in various case scenarios in coronary disease. Even though my topic has been given only thrombotic lesion, we'll show you the use of laser in different scenarios. So we have a 26 cases experience with this laser in Kim's Hospital in last 10 months after we bought this. So let us start with some of the interesting cases. This is a patient who is 65-year-old male, coronary disease, acute coronary syndrome, inferior wall MI with right ventricular MI, and is a post-CABG patient in 2006 in USA. We don't have any details. So we immediately patient took him for a CAG for graft angio, showed left main coronary disease with native triple vessel disease. Lima to LAD was patent, REMA is occluded, SVG to PLVW, proximal total thrombotic occlusion, and severe left ventricular dysfunction. So the plan was primary PCI to SVG to PLVW. And this is his ECG with an acute MA with broad QRS with gross STT changes, even the positive wall changes also there. And this is his angiogram. This is a native coronary arteries. You can see that Lima is filling retrogradely. And the second picture is showing that RCA is total occlusion, and you can see the SVG graft is totally occluded. So once the total SVG graft is occluded, we used a 6F AL1 guiding, and we used a Rinaldo wire, and we dilated with 2 into 12 NC balloon, and we could establish a TIMI 2 flow in the coronary artery. And then still there was a lot of thrombotic burden. We were hesitating, but if you see, it's a large branch and it's a very dominant right coronary artery also. And we didn't want to do any mess up in this patient. If we lose this vessel, the patient may die. So we dilated with 3 to 48 millimeter balloon. Still we couldn't get a satisfactory TIMI flows. So what we did next day we brought back the patient and used a LCA laser, 1.4 millimeter LCA laser. And then again we used 0.8 also, and we lased up to 40 to 80 fluence, and then we got a good flow. So we didn't stent on the same day, we got him back on the third day, and then we stented the whole SVG graft with 3 stents, 3.5 into 48 Zion's expedition, 3.5 and 48 Zion's expedition, and approximately distally we used 3 into 60 biomorph. So these are final results we got it. You can see there's a nice 3 flow, and it's a huge PLVW. You can see the OMs also arising from it and the PDA. And the patient is doing fine, 1 year follow-up, and there's no restenosis, and patient is fine. So basically in this case, the LCA was used to lessen the thrombus burden and prevent choking of the distal coronary circulation. If you have noticed that we have not even used a filter in this, because we pulverized the thrombus, we burned the thrombus, and we pulverized it with the lasing so that there was no distal occlusion. So that's what we could get in this patient. Just coming to the mechanism of action, it has a photochemical action, it breaks molecular bonds, it's a photothermal action and produces thermal energy. It has a photomechanical action, it creates kinetic energy. The photochemical mechanism, it's breaking the molecular bonds, it is how it acts. The duration of the laser pulse hits at 135 billionths of a second, that is 50 microns penetration. So billions of molecular bonds are fractured per pulse. This is how the photochemical mechanism acts. The photothermal mechanism, this is by producing the thermal energy. Absorption vibrates the molecular bonds of the block. This vibration expanding the vapor bubble forms 100 millionths of a second and 1000 times the duration of the actual laser energy emission. This is the photothermal mechanism. The last one is a photomechanical mechanism. Expansion and collapse of the vapor bubble breaks down tissue and clears byproducts away from the tip. Byproducts of ablation are water, gas and small particles. So nothing will choke the distal circulation. When you, by kinetic energy, the thrombus which is broken, it becomes water, gas and small particles, and then they flow down the microcirculation. Entire process, the time per pulse is 400 millionths of a second. So this is how the laser acts, by photomechanical, photothermal and photochemical action. The second case example is how we used in an instant restenosis under expanded stent. This fellow is a 65-year-old male, post PTCA to RCA with 3.5 into 40 millimeters aluminum stent. He was again presented with the NSTEMI. So again, this is again acute coronary syndrome on 8th of 21, and patient angio showed ISR of instant restenosis of the RCA, and patient had post-COVID in 2020. So what we did, we pre-dilated with a NC balloon, and then we used a 0.9 millimeter LCA coronary laser catheter with 60 fluents given. And then we finished the procedure with 3.5 into 10 NC balloon, and we used a 3.5 into 20 drug-eluting balloon. So this is the patient, and this is the ISR of RCA, and this is a pre-dilatation with 2.5 into 12 millimeter NC balloon. And when we use a laser, 0.9 millimeter laser, and that's a mosaic balloon, 3.5 into 30, and this is a final result with the LCA balloon. And this patient more than 1 year follow-up, he didn't have restenosis. We plan to do check angio again to see the status. The single lateral pulse timeline which give, the photoablation part is very minimal, and the rest of the part is rest period. Only 1.3% of the time is a photoablation time, 98.7% is a rest period of time, so that in the meantime the overheating doesn't occur. The 5 S of laser success are selection of the correct laser catheter, sizing of the catheter, settings in which it has to be used, the saline how to use, and the speed with which the laser catheter has to be proceeded. Selection of patient, multiple morphology lesions, which I have told you already. Sizing, very important, catheter to basal site, the tighter the lesion, the smaller should be the catheter. That is 0.9 you have to use, you should not use 1.4. Setting the fluency and pulses. Flush is very, very important. You should have continuous flush with the saline with 1 to 2 cc per second. The advancement of the speed also should be very slow. It should be 0.05 to 1 millimeter per second. These two things are very important. So coming to another patient, patient in acute MI thrombus. He is a 35-year-old male. Anterior wall MI, patient was thrombolized with reticulase outside and with moderate LV extension. He came with a cardiogenic shock. Angio was done outside, single vessel disease, and it showed LAD thrombotic occlusion with a thrombus in left main. Because the patient was considered high risk, he was shifted to our hospital. So again, this patient, we also didn't want to do anything with the thrombus here. So we just did a LCA and laser assisted IVUS, and PTC only was done for him. So this is the thrombus. If you can see the other view, there is a huge thrombus burden. Can I go back? So in the next film, you can see that there is a huge thrombus burden in the LAD territory, right from the ostium of the left main. So we didn't want to stent him. So we did LCA laser 0.9 laser, and we stabilized the patient, and he was in cardiogenic shock. We put intra-aortic balloon pump, and we didn't stent the patient and send him home. And we did a check angiogram after 1 month, and there is no need of stent, and the artery is fully patent. And now we're planning to do 1 year follow-up angiogram also for him, and to see how the laser works for in this group of patients. There's a small coronary aneurysm there, and there's ectasia also there with stagnation of thrombus, which is not going to harm him. Again, laser ablation technique, the size of the catheter, as I said, should not exceed 2/3 the size of the reference vessel diameter. Saline is very essential to remove the contrast from the photoablation location. If you use contrast during photoablation, there will be a lot of burn that can happen and perforations can happen. Even blood should not be there. And in fact, with more experience, they say that you can use, if you are not able to burn or you are not able to get a desired result, you can use contrast with laser ablation, but that's only when you do more than 100 cases. When you have more experience how to use the laser, you can use the technique. And advance very slowly, less than 1 millimeter per second for cleaner and larger lumens. You should advance the catheter very slowly. And the catheter doesn't advance on its own. You have to slowly push the catheter with your hand. This is how it shows a 6 centimeters lesion is 60 seconds. Minimum of 1 minute you should take to cross the lesion. This is a small guideline. This should be less than 1 millimeter per second. Otherwise, you will not get an optimal result. The photomechanical effect, this is how it has happened. If it's a 45 fluents and 60 fluents, there will be two. The more the fluents, the area of width will be more high. The expanding vapor will be high. So this is 2 millimeter catheters, 45 fluents. You can see the amount of vapor bubble, and 60 fluents, amount of vapor bubble which is created. Coming to the next scenario, instant restenosis, which we think is going to be very boon for patients who have instant restenosis. We always avoid putting a stent in this group of patients. We don't like to stent instant restenosis because whatever little experience we have, the restenosis is very high with them when you keep a second coat of metal jacket. Especially if there is a restenosis in drug-eluting stent. If it's restenosis in a bare metal stent, definitely we don't mind putting another stent. But if it is restenosis in a drug-eluting stent, we try to avoid putting another drug-eluting stent, because most of them it will be a probably with under-expanded stent, or there is a lot of fibrous plaque which is outside the stent which are not able to break. So what we learned with this laser is, whenever you want to do something outside the stent to soften the fibrous plaque there, if you use laser in the stent, the fibrous plaque which is there outside the stent gets softened. You expand with a cutting balloon, you expand with a drug NC balloon, then you just leave the procedure with a drug coated balloon. They do extremely well. This is again another patient with a instant restenosis in the mid part of the stent, if you can see there, and we had difficulty in expanding the stent even after using a cutting balloon. So we use and OPN balloon. So we used a 0.9 millimeter LK laser catheter, and if you see that Wolverine cutting balloon, we didn't get a good stent expansion. So we have to use a laser, and then we finished the procedure here because there was a distal restriction. We used another stent, and the patient did fine in this procedure again. The slow advancement is a very key in these procedures. So if you see the lumen diameter with fast advancement, you will get a smaller lumen gain. If you see the next picture with a slow advancement, you will get a better lumen diameter. This is very, very important in this group of patients. Again, it's shown in other picture. The slow advancement is the key. Slow advancement, you get a 6 millimeter lumen, whereas fast advancement, you get a 3 millimeter lumen. So this is another scenario where the patient went to two different hospitals. They tried PTCS stent, and they could cross with a wire, but no hardware could cross. So this patient came to us. Is a post CABG in 2010, Lima to LAD, SVG to OM and RCA, native triple vessel disease, acute coronary syndrome in August 2021, SVG to OM and RCA occluded, attempt to PTCA to RCA, unsuccessful one hospital, and second hospital again they took as a chip PTCA to RCA, unsuccessful other hospital. The second time the fluoro time was very high, and the procedure was abandoned. And then he came to us, our hospital, and this is his native coronary. So you can see the RCA filling retrogradely. And we used a Saul guiding and Gayat 2 wire to cross the lesion with a 6F guide. And we use, once we crossed with the Gaia, if you can see this very critical lesion in the mid to distal part of the right coronary artery. And we use 0.9 millimeter LK laser catheter with fluency of 60, and the second fix with 60 megahertz with guide extension support, because it was very difficult. You will see the extreme tortuosity there. Once in this again I'm telling that with the laser catheter we could not completely exit the tight lesion. We spent a lot of time in the lumen, and that definitely softened the nearby areas also. So it's not that you need to pass through and through the laser catheter to get a fantastic result. So what we result here, after so many fluents and burns, we couldn't pass the catheter totally, but that definitely allowed us all the balloons to go. We used to start with 1.5, 2.5, 3, and then 2.5 angioscalp balloons, and then we finished the procedure. We just cross-check with the other injection, and this is a final result of that RCA. We used 3 stents, and it was a very good result. We did a follow-up angiogram last month, and the stent is patent. So this again another in-stage stenosis, and this is a 25-year-old calcified saphenous venous graft. So you know the saphenous venous graft, after 20 years they start getting calcified, and this was CABG in 1997 with Lima to LAD, SVG to OM, SVG to RCA, and then patient had a class 2 angina, and Lima to LAD and SVG to OM and proximal 90% tight lesion. I only did stenting in July, September in SVG to OM. At the time I was not comfortable with the stent procedure because I couldn't deploy the stent properly. So after deployment of the stent, I used OPN balloon to further crack the stent, and it accidentally opened the stent, but at least the flow was good. So at least I thought I prevent a acute stent acute stent thrombosis with a long-term result will be fine. But he came with a restenosis in 6 months. And this is his angiogram. There's a restenosis, and where the partly undeployed stent was there it is no. So we again didn't want to put two stents in a calcified SVG graft. So we lace there. Definitely we felt that there's a balloon expansion. We didn't have plant, and we use a drug-eluting balloon, 3.5 into 20 mosaic balloon, and patient came for follow-up. He is doing very fine. So summarizing, these are indications of lacing, acute coronary syndrome, MI, where there is a lot of thrombus burden, where you are worried that your stent might cause no refluo, just to lacing, the thrombus burden comes down. Probably bring them a second bag, and if you think it's atherosclerotic plaque, you can stent them. Non-crossable, non-dilatable lesion, balloon flareure, where you can't cross with anything, you can cross with this lens. CTOs also can be used, again, where you can cross with the wire and then you cross with this lacing. Experts in the world, without crossing the wire, they are using laser. We're still not that much expert. Under expanded stents, definitely indication. SVG grafts, definitely no reflow will be less. Bifurcation lesions were not used much, especially the ostial of the bifurcation, so that the opening of the ostia will be very good. So restenosis in the side branches will be less. The contraindications are unprotected left main disease, because we are putting the catheter for a long time. Any subintimal course of the PCA wire, as is CTO, if it's a small, then it's okay, but if it's long, it is not good to use, because the chance of perforation will be high.
Jain sir, almost 15 minutes.
Yeah, I'm finished.
Yeah, a couple of questions, sir.